Thank you, Alisa, for inviting us to do the presentation for Foundation Year 2 Standalone program. And I saw the hands a minute earlier. I think there are a couple of you, more than a couple really, that applied Foundation Year 2 training. And we have on the speaker, Dr. Guven, who also completed Foundation Year 2 Standalone program, who will share valuable information with you guys, such as eligibility, how to apply for the next year, and experiences, etc. So I'm gonna need volunteers for the mocks, and we can start with the mocks, and then we can go through like the eligibility stuff. You can always find them on the handbook, and we can continue with experience, Dr. Guven's. Okay, so I'll share my screen. Give me a minute.
In the meantime, if you'd like to be volunteer for the interview mock, please put on the chat. That would be great.
Can everyone see my screen?
Yeah, we can see that.
Okay, so I have a couple of slides to guide you how to prepare for the exam. And for this year or next year, this also applies even non-training jobs or other training jobs in other specialties. It won't be sufficient for other specialties, but for baseline information for any junior doctor positions, these are valuable sources that I think you'll have to go through. General information about interviews, you can find those from the handbook as well. So they have SJT, as you know, situational judgment tests, and they generally pick up the people who scores top. They conduct interviews virtually. They last for 20 minutes. You get asked multiple questions, including at least a clinical scenario. At least one panel member is a clinician, generally it's more than one. All applicants will receive a breakdown of their scores for each interview question and detailed feedback from the panel. So what happens really when you go to interview, and as Alisan said, I was one of the previous examiners, so how it's contact is virtual, you come in, similar to any type of virtual interviews, someone checks your ID and everything. You should make sure that you have a smooth connection. You shouldn't disconnect. Obviously, they send you all the instructions in advance, such as how many minutes in advance you have to join and etc., which type of ID clarification they need, etc. Someone checks that. So when it's time, then you come in and they do the interview. So the panelists ask you questions. You have 20 minutes. Generally, there are 4 or 5 questions, and they score you depending on your answers. Okay. So how to prepare? Oxford Handbook of Emergency Medicine and Foundation Program, I think, are the most valuable ones because they are specific to the grade that you're applying for. Apart from it, for further detailed information on some certain topics, you can go through clinical medicine, Oxford Handbook of Clinical Specialties. If you are working in an NHS trust at the moment as a FY1, or if you have some sort of access from somewhere, NHS trust guidelines will reflect the pathways there anyway, so you can look at those as well. And you can also go to trustable websites such as Royal College of Emergency Medicine, Royal College of, for example, Physicians, and you can go through Geeky Medics. There are lots of websites and YouTube channels and everything nowadays that you can benefit from. Okay, so do we have a volunteer? Shall we start?
No one volunteered yet. So maybe we can just give them. Okay, there is one volunteer.
Vatsal, yeah. Am I pronouncing it correct?
Yeah, Vatsal. Yeah, Vatsal. Yeah.
Okay. So Vatsal, do we have a volunteer? Shall we start? No one volunteered yet. So maybe we can just give them. Give them. Okay, there is one volunteer. Vatsal, am I pronouncing it correct?
Yeah, Wassal put their hand, and also Gülnihan also sent a message through chat. Okay, yeah. I can.
If we have two, we can split the questions and ask two questions to each, maybe.
Yeah. I think that'd be great.
Okay, so let's start then. Can you unmute them, Alisan?
Yeah, I will unmute Watsal and then. Okay, yeah. Well, let's start.
Hi.
Hello. Hi, Watsal. Am I pronouncing your name correct?
Yeah.
Okay. So the things that you need to remember, no one's going to remind you in the exam like I did, but you have 5 minutes for each question. So when you construct your answers, think about that on the back of your mind, okay? So
Okay.
could be one of those questions about your CV. So I'll ask you about the basic one. Tell me about yourself.
Okay. Thank you. First of all, thank you for giving me opportunity. So, myself is Dr. Jetani. I'm a GMC registered doctor. I hail from India. So, basically, I've graduated in 2019 from VNSU University from the India, and since followed by that, I completed a 12-month internship with rotation in all medical and surgical specialties. During my foundation year, I found my interest in general medicine. So, followed by that, I started working in general and acute medicine as a house officer. And I have almost around 3 years of experience in this field. And at the moment, I am currently working in the acute medicine, where my general duties involve attending handover meetings, daily clerking of the patients, performing routine and emergency procedures, and following the consultant's advices. And besides that, I have done 4 weeks of clinical attachment in Heartland Hospital, Birmingham. So besides clinical work, I always engage myself in teaching initiatives. So in my current job, I regularly teach nursing staff on a weekly or twice a week. And during my school day, college days, I was used to teach medical students, first year and finally medical students. So besides that, uh, I have been engaged in quality improvement projects, such as I have done 4 clinical audits, one QIP, and I have also published research articles. And I believe that I have a good leadership and management skills. And also, in terms of training, I have done BLS and ALS from the European Research Association Council. And as I am very keen to pursue my training in the internal medicine, I'm preparing for MRCP, Royal Membership exams. And out of medical world, I like to spend my time in doing playing volleyball, doing cycling, and going for traveling. Thank you so much.
Okay, thank you. That's great. I think you gave a very good summary of your background and CV. It's always good to let them know that you actively work in medicine and that you're keen for whatever specialty you are, and give like a general background about yourself like you did. That's great. Thank you. And I think you use your time wisely. That's also very important in the exam, because it can give you a couple of minutes. You still have 2 minutes, so you can have this minutes for yourself to use for the next questions if you have a question that you want to come back later on. Okay, so this is your first clinical question. What's all? You are the F2 in the emergency department. 30-year-old man presented who said he developed acute shortness of breath after taking an antibiotic tablet prescribed by his GP earlier that day. He tells you that he feels like it's a man, so his throat is closing up. On examination, he's wheezy and has rashes all over his body. So you're the doctor, what would you do?
All right. So from the clinical background, which is given to me, it seems like a patient is having anaphylaxis reaction secondary to his antibiotic. So I will quickly assess my patients. I will use a ABCD A to E approach. I will first make sure that his airway is patterned as he is choking. If he's like so, I will start him on oxygen. high flow oxygen 15 liter via NRBM mask. And as I'm suspecting it could be anaphylaxis based on the findings, I will immediately give my patient adrenaline. I am 0.5 ml, one is to 1000. And followed by that, I will quickly assess his breathing, B part. So I will check his chest. I can appreciate that there's a wheeze. And so I will also would like to start him on, I will change his mask to, I will give him salbutamol via nebulizer mask. And coming to the circulation part, I will check his pulse, blood pressure. I will attach this to the monitor, checking his ECG. And definitely I will secure his IV lines. And I will start, if there's any drop in the blood pressure, I would like to give him a fluid challenge. Hello.
Yeah. Do you want to add anything? I can hear you.
Sorry, there was a big interruption. Just give me a moment. Sorry.
That's okay. That's fine.
Sorry, I'm just facing some technical glitch.
Don't worry. I think you answered most of the question, so we can go through the answer. I think you did great. You defined it correctly. This was a case of anaphylactic reaction, but if you're not sure, for example, it might not be available to on all the questions, but if you have time, your struggles, etc., you can ask if they have any data observations. And if they have, they'll be able to tell you if the patient has it's like tachycardia, hypotensive, if they have like cold, clammy skin, the things that you'll have in the anaphylaxis. They might have or not give you the information. It's up to them, or if it's available to them. We don't know this. But if you struggle, you can always ask for those stuff, which can guide you better for your differentials and stuff. So what could give you you defined it correctly. I based this on an anaphylactic case. But if you would tell me, could be due to shortness of breath, could be PE, sepsis, ACS, but due to antibiotics, I'm thinking of anaphylaxis, that would be correct as well. So no harm in giving those differentials as well. And you went through ABCD approach, that's correct. And as I said, you can ask for more findings. They might give you straight away if they have, they might not have, they might tell you this is the only information that we have, but if you have time and you're struggling, no harm in asking. Yeah, you recognize that this is a potential life-threatening medical emergency. And you mentioned about the IM adrenaline right away, that's good. It's always good to learn the doses for the life-threatening emergency. You gave me the dose as well for adult dose, that's great. You mentioned about the salbutamol and oxygen and that stuff. So apparently you know the management algorithm. The only thing that you could also mention that because you're F2, you can inform your senior as well. You diagnose, you decided for the adrenaline, you're gonna follow the protocols, but you can inform, depending on the setting you are, your regular consultant or whatever it is, you could mention you need to remove the trigger. This is antibiotics already in the system, so that's fine. But let's say if it was for something else that you could avoid, you can mention that one as well. You could also mention discharge and follow-up appointments. And if you look at the guidelines, they also mention about the muscle tryptase measurement. You shouldn't delay the treatment, but muscle tryptase measurements generally done in people who have anaphylactic reaction, ideally within 2 hours. So it could give you some extra points. So that's why I mentioned if you go through the Royal College of Emergency Medicine in this case, on their website, their guidelines, or Oxford Foundation guidelines, then you'll have all the details that you can mention extra points. So they can put you a bit higher situation in the rank compared to your peers. But you did great. Thank you very much also. So that's all right. Shall we continue? with our next volunteer?
Yeah, our next volunteer is Gülnihan. And also there's another volunteer who just put their name in the chat. Do you think we can accommodate a third person?
And what we can do one each. So I think it will be fair because the first question for Wassel was CV anyway.
Yeah.
So it wasn't anything special. So I think, yeah, we can give one question each to them.
Sure. Cool. I'll just allow Gülnihan to unmute. Okay, yeah, Gülnihan, you can unmute yourself.
Hi, Gülnihan. Hello.
Let's wait for a sec. Hi, Gülnihan, can you hear us? You can unmute yourself right now, if you'd like to. But yeah, maybe we can continue with our third volunteer, and then we can go back to Gülnihan.
That's absolutely
after that.
fine.
Yeah. Okay. Okay, Najib, you can unmute yourself.
Hello.
Hi, Najib. How are you?
I'm doing great. Thank you so much for giving me the opportunity for this mock interview session. It's really a great session, helping us a lot. So looking forward for it. I have an interview tomorrow for a non-training job in acute medicine. So I really wanted to get opportunity for this mock interview session.
I think that will be valuable for you as well. As a SHO level, this is a type of structure that you're expecting anyway, be it FY2 or any other SHO job. So I think it will be valuable. Thank you for joining us today. So you're ready for your question?
Yeah, sure.
Okay, so it's coming. I put the algorithm here for the other question, but you can find those online. So I'm going to pause that. Okay, so you're the FI2 in the ward of elderly. 76-year-old Mrs. Norris's daughter tells you that she is concerned Mrs. Norris isn't herself. She feels she is confused. What would you do?
Okay, so first of all, what I will do is that I will go and visit the patient, check my patient details by looking at the patient wrist and confirming that I'm looking at this right patient. I will check the patient that if the patient is able to talk with me and if the patient is able to have a conversation with me so that I can ask in a better position regarding the patient condition. As it is being mentioned to me that my patient is confused, so I will follow the usual ABCD approach to make sure that my patient vitals are normal. I will check if the airway is patent. After that, I will attach the monitor and look for the patient respiratory rate, oxygen saturation, and if there is any changes or which is important, maybe the oxygen saturation is low, I can give oxygen to my patient accordingly. Then I will move forward to the circulation part. In the circulation part, I will look my patient pulse, blood pressure. Along with that, I will also do some examination, the chest examination, looking for the heart sounds and everything. And in the meantime, what I do in my daily practice is while I'm assessing acute patients, I also take a history along with it while I'm assessing my patient according to the ABCD approach. So I will also ask one of my staff member or if anyone is present along with myself to give me a brief history of the patient too, that why the patient was being admitted at the ward, what was the patient complaints, and what symptom the patient had when the patient was admitted at the hospital. And I will continue with my ABCD approach. I will check the patient blood sugar level in the depot and also the pupil of the patient. Along with that, I will check the temperature of the patient too. And if I feel that there is any kind of sign or symptom that suggests me a differential diagnosis, I will look forward to it. And I will do a generalized examination on my patient in the EPOT. Along with that, as my patient is a bit, 76-year-old, now I will look forward at what can be the differential causes of the confusion in this patient. In old elderly patient, most commonly it occurs because of either a UTI. So I will take some investigations regarding that. I will send an ABG, complete blood count, urea electrolytes. Along with that, Some patient at this age, they may also be suffering because of a stroke attack. So I will do a generalized neurological examination of my patient so that to find out what's happening to my patient in the first place.
I'll give you some findings then. So you did observations. Patient's pyrexic 39.3 Celsius, and you did. Apart from it, observations are not really worrying. You did neuro exam, so I'm gonna give you some details about neuro exam as well. Normal tonus, power 5/5 in all extremities, normal sensation, normal coordination, no cranial nerve deficit. And you also mentioned about the blood test. So when you went to request blood test, you actually noticed from 2 days ago, there's some blood tests requested, but no one put the patient on anything. CRP was 350, and you went to have a chat with the nurse, and the nurse tells you, oh yeah, she has smelly urine. So what would you do now?
Okay, so as I can see that my patient temperature is toward the higher side, and my patient is confused too at the moment. And also, my patient CRP was towards on the higher side, and the patient urine was smelled too. I'm happy with the neurological examination regarding, so I'm less thinking about the stroke. It can be because of the acute infection, because of acute urinary tract infection in my patient. The patient temperature is on the higher side, so I will give some paracetamol medication to decrease the temperature. Along with that, I will also check the blood pressure of my patient. If the blood pressure is low and the respiratory rate is more than 25, it shows that the patient can be in a form of sepsis. So in the sepsis protocol, if my patient vitals were like if the respiratory rate was greater than 25, if the BP was less than 100, if the heart rate was towards on the higher side, I will be thinking more regarding the sepsis protocol. So in that sepsis protocol, I will be following the normal protocol, which is taking 3 things and giving 3 things. While taking 3 things, I will look forward to the ABG. I will take some sample for the blood culture, and along with that, I will attach urine catheter to monitor the urine output. At the same time, I will give oxygen to my patient, give IV fluid to my patient, and also I will talk with my senior and also check for the local hospital protocol regarding the antibiotics for my patient, which I have to give as soon as possible because the CRP is quite on the higher side.
That's great. Thank you very much, Najib. You did very well. Well done. Only feedback that I can give you is that if this was a FY2 and standalone program, if you answer your CV questions very quickly, if you get asked one, obviously, because guidelines may change, we don't know what they're gonna ask, for example. And if you have a couple of extra spare minutes, you could use on these questions. But apart from it, if it's only just timed 5 minutes and done, some might tell you, done, move on. So, but since you said you have interview for a non-training job, in non-training jobs generally timing is a bit of less issue. So I think you'll be okay. So yes, you did. You reviewed the patient. You mentioned about taking the history, and you mentioned about ABCD. You mentioned about stroke, which would cause you to get CT head request put in, but then later on you excluded. So that's why I'm thinking probably you didn't mention that one because I gave you the observations and stuff. What you could also mention in geriatrics, they like to do AMTS, some sort of cognitive testing where they ask like age, time, year, and they're like home address, date of birth, like who's the current monarch, and if they score like 6 or less, is delirium or dementia, then it is for the exploration, for example. So you could want to confirm that confusion with the patient. You mentioned about the blood test, and these are the full set of blood tests that someone would do for a patient on confusion. And you also mentioned about the most commonly seen causes for an elderly patient to experience confusion. You mentioned about the UTI and other stuff, which was our case was UTI here, but you could also mention polypharmacy, dehydration, constipation, infection, pain, injury. Elderly people are prone to have experienced delirium confusion more than the young people. But you did great overall. Very well done.
Thank you.
yes, you identified the potential underlying cause, UTI. You mentioned about the treatment, checking the local guidelines for antibiotic. You mentioned about the paracetamol. That's great. And so you mentioned the management. That's what I'm meaning. It's always good to mention management, even if you don't know the medication. You can say, I'll check with my senior for the management, or I'll go to local trust guidelines and have a look how to manage this patient, for example. So you're not just taking history and going away. So you know what to do, where to look at in this information. And it's one thing you could also add, maybe if you have time. I think this is also important. I specifically said the bloods were from 2 days ago.
Yeah.
And someone tells you, oh yeah, she has smelly urine. So obviously someone did something, but nothing has been followed. And maybe if this was actioned before, maybe she wasn't going to get UTI. So you need to have a chat with your seniors about it. And if there's a need for ethics, you may need to raise this for patient safety. And obviously you have to mention that everything needs to be recorded into patient notes as well. But very well done. Thank you.
Thank you. Thank you.
So we can move to the last question.
We
Are you
have
ready, Julie?
we have some questions on the chat if you'd like to
Yeah,
maybe
go on.
yeah. So the first question is someone asks if all the clinical questions in FY2 standalone interviews are need to be approached with ABCDE, even when it is even when it's not an emergency scenario like this one.
I'll answer this after the last question. That's what last
Okay.
question will answer the question.
Okay, sure. And the other question is, can we say we can start on empiric antibiotic whilst informing seniors?
Well, it depends on what question they ask you. If it's something, for example, if you're in the A&E, you'll need to give medication instead of leaving them there. If they're having sepsis, for example, you'll have the guidelines in front of you. But it's not difficult to find which medications used in the trust. All the trust has micro guide and local guidelines for which situation, which antibiotic you have to use. So this will also answer the first question. It depends on the situation. If patient really difficult condition, pyrexics, you think gonna go into sepsis, yeah, you have to put them on something. And obviously, instead of empiric, best would be what's stated in the guidelines. But if you don't have anything and you have to give something, why not? Because you have to mention about the management, you have to mention about the treatment. So just to let you know, what I'm saying is not like definitely you need to do it kind of situation. What they're looking at is that I'm trying to give you a guidance. I'm not trying to tell you how to teach UTI or what to do. You're all doctors, you know how to do it, and you'll learn if you don't know it. What I'm trying to tell you here is that to guide you in the interview process. So in the interview process, if you know about the management, you have to mention it. Even if you don't know about the management, you can tell that I don't know the exact treatment, but I'll have a chat with my seniors. Or I can go into guidelines to look at how to manage these people. So you can not just take the history and go away. So don't really pay attention, or whether it is nitrofurantoin first line in this trust, or is it trimethoprim first line? Can I use it in the elderly? So there are lots of other factors, obviously, when you prescribe something. So your attention in this presentation, in this session, is how to structure your answers and what things you have to mention to get those points. Obviously, if you have time to detail them, that's great. Yeah, can we move to the last question?
Yeah, let's do that. So I think that the only problem is, I think Gülnihan mentioned that she's having some connection problems. So Gülnihan, if you like to give it a go, we can try just to see if your microphone is working, or we can ask for another volunteer.
Can I mention something?
Umur?
Yes, can I mention?
Sure. Yeah,
hello.
please.
So because I did the F2 standalone interview, you don't have time. You literally don't have time. So you're going to say, I'm going to do bloods, including FBCs using ECR, PLFDs. Because every time you stop, I'll do some blood tests. They'll be like, which blood test are you going to do? So you lose time. You should be very on it, confident, tell what you're going to do. And you're going to give antibiotics according to your local guidance. So just make sure that you don't have, like, aware of that you don't have time. So as Libby has said, it is a very limited time for your interview.
Thank you. Thank you. That's great.
Yeah, don't drown into details. Yeah.
Okay, so it looks like Julian is having connection issues. If there's any other volunteer, just please put your hand up, or you can just put a message on the chat. But also in the meantime, we have another question that we can have a look. The question is, since it says the patient is confused and her daughter is Iran, can we ask questions about the history to her daughter?
You can. Why not? You can get the history from the nurse. You can ask the daughter, obviously you can ask the nurses, or if there are any other doctors or healthcare professionals that has taken care of that patient. It will be collateral history, the one you collated from the daughter, but they're valuable as well. She's the one obviously who's the family and will know what's normal for her mom. And if you're the on call and never met the patient, it will be difficult for you to know what's the normal for person. But that's why they have all the AMTS and other sorts of things that you ask patients to assess if they're like has delirium or confusion or whatever. So you can do it. Why not? So as long as you say, I take the history, as Umur said, probably only time that you will have is that I'll take the history. You can say, I'll look at the notes, speak to nurses, speak to daughter, I'll take the history. So as long as you say that you're gonna take the history and review the patient appropriately, that's fine.
Okay, thank you. It doesn't look like there's any volunteers. Maybe I can volunteer.
Yeah,
If
yeah. Okay. This is not a difficult one anyway, so it's an easy one.
Cool. Yeah, thanks.
Okay. I think Watsal put his hand up. Do you want to be volunteer for the last one, Watsal, again?
Okay, yeah, we can do that.
Okay.
You can unmute yourself also.
Yeah, hi.
Do you want to be volunteer again?
Yeah, if you.
That's great. Okay. So, question 3. Here's your question. You're the F2 in the obstetric and gynecology ward. You're asked to review a 24-year-old lady who is 24 weeks pregnant. She's been admitted for pneumonia. On examination, you notice bruises on her bilateral arms. She tells you that she doesn't know how those happened. There are no concerns from your colleagues, and there are no medical causes for it to happen when you look at the history. Her management is sorted. She's waiting to be discharged later that day. You see her in the presence of her husband. Husband gets angry when you ask questions about the bruises. The patient tells you she's fine, she's keen to go home. What would be your approach?
All right. So I will approach my patient first, and as per the scenario, I can appreciate that there could be possibility of any non-domestic violence. So I will first make sure that I'm talking with my patient alone. I will politely ask the husband to leave the area, and then I will first assess whether she's medically okay or not. Does she have any symptoms of pneumonia? Has she recovered from or not? Any fever, any cough? And I will then I will start asking. I will give her some confidentiality about to just let her open up about the bruises. I will ask brief history of how did she get and how has bruises often, how often does she get. So then
Okay.
right, so
Anything else
then
you want to do?
yes, I, like if she's not feeling comfortable, I will again try to give her some sympathy and support by giving her like we are here for you to help you, and also if she by the time if she opens up, then we can involve some services, social services as well. If I am I can involve my senior as well if she opens up about the abuses.
Okay. So for the sake of time, to give more time to Dr. Guven as well to go through his stuff, I'll quickly go over this. Yeah. Okay. This is a possible safeguarding question. You need to well done, Watsal. You I think take most of the points here. So it will be beneficial to see the patient without the family members. You can concern your concerns regarding bruises. I specifically put that there is no medical condition that would cause it. I didn't want you to think, oh, whether she's on any some stuff like blood thinners, for example, that it may cause it. But you can go through stuff and experience those people. That's why you need to discuss your concerns. And you mentioned about the domestic abuse. Yeah, that's good. And what you can also do, you need to inform your senior or consultant about the decision, because they were looking to discharge the patient one day. So if you have any concerns and think that she's been through some sort of stuff, it's always good to inform a senior who knows the protocols better, and you can get further advice. And if you're really suspicious that, oh, this is definitely or high possibility that there's a safeguarding issue, that you need to refer the patient to safeguarding team. If you're not sure, you can even ring them and say, I have this, can I get an advice? They always give advices as well. And if you're not sure, again, you have to, regarding the safety of the patient, you have to delay the discharge. You shouldn't discharge patient right away. So the points to mention: possible potential domestic abuse, informing seniors, referring or discussing with safeguarding team, and delaying discharge. This was the points that you should have mentioned in this case. You mentioned some of them. Great. Okay. Let's move on. So I think that question would answer, and the recommendation would answer the previous questions about ABCD. Your answer should be systematic, but obviously this depends on the case. If the case doesn't need you to go through airway breathing, circulation, etc., you don't have to. So it's case dependent. And also, it's always good to show them that you know how to approach the cases systematically, which will help you with your differentials. And learn how to approach the most commonly seen emergency. Do not forget to communicate to your seniors. Do not forget to record your findings, differential, and management plan into patient notes. If you have a friend that's also preparing for interviews, it's good to practice with them. You can ask each other questions and maybe find the things that you think you're missing from each other and help each other. For FY2, it's only 20 minutes. So as Dr. Guven said, you might not have time to mention all the points that I put here, but that's why you have 4 questions. So you don't have to full mark. Obviously, higher is better for your rank, but as much as you can mention and construct your answer wisely in the time given to you, then there is no reason that you won't succeed. Okay, so I'll stop my presentation here and pass to Dr. Guven. Thank you very much, everyone.
Thank you, Rabia. It was amazing, and I'm sure people really benefited from this. I'm just going to do a quick short introduction for Dr. Umar Güven. Umar completed his FY2 standalone when he started his clinical practice in the UK, and afterwards he went to the internal medicine training and successfully secured oncology higher special training number. And he's amazing in terms of structuring his medical career, and his insight will be really valuable for everyone. So thank you. The microphone is yours.
Thank you for your kind words. That's a bit of a lie, but I'll take it. Thanks. I'm unable to share my screen.
You should be. Are you getting? At the moment, we are not able to see, but you're a presenter, so I'm not sure.
Let me check something. I think it's the no, it's not allowing me to share it.
Really?
Can you share it? You have my.
Yeah, I can. Sure. Give me a second. That's okay. Okay. I'm going to share it now.
Share it again.
Yeah.
Okay. I think we can see yours. Ali-san?
Oh yeah. Let me know whenever you want to
We
change the
can see the
presentation.
screen.
Yeah. Can you move? First slide. Okay. So I'm going to talk about the person specifications first, where you need to have these essential criteria in order to get into long listing process, where they find which applicants can be able to have the interview. So the first one is that you need to have a primary medical qualification, your degree, recognized by GMC, and then you need to have a full registration and a license to practice. So you need to have your GMC registration by the start date of the program, which is the first Wednesday of August. And you also, it was changed since I did my foundation year 2 standalone in 2020. We didn't need to get valid ILS certificate, but it was mandatory to have ALS at the end of your foundation year 2. But I think this current year, you need to get your valid ILS certificate by the start of the program. And you should not be working as a current F1 or FY2 in a training program. And someone who completed their foundation training are not eligible to apply for standalone FY2. Yeah. The other criteria is, so these are available on UK Foundation Program website, so you can go and have a look again. I'm just going to read through those criteria. You should have a proper right to work as a doctor in the training in the UK by the start of FY2. The desirable criteria are not essential, so you don't need to get them, but they give you a better score when you're presenting your CV, basically. The other essential criteria that you should know your good medical practice and be a good doctor with good standing and fit to practice medicine. You should know about your clinical governance and how to improve yourself and the patient care. Yeah. So anyone who's applying for FY2 standalone should read the foundation program curriculum, the expectations of an FY2, what skills you should have before you start, and what skills you should gain at the end of your foundation training. So applicant must demonstrate an understanding of the outcomes of the foundation program curriculum. If you're working in NHS, that's a desirable criteria. It's not necessary to have. You can be working outside in the UK and come for standalone FY2 straight. So you need to have evidence of CPD is a good practice that you are keen to learn and improve your skills, and participation in clinical audit, doing projects such as research or quality improvement projects are really helpful, and they will give you a better score. The other essential criteria is the language and communication skills. If you go to the next slide, I can go through more. You need to prove that you know English well, and these are either you have a primary medical qualification undertaken in English, including all examinations solely in English, and you spend 75% of your bedside manner, like bedside contact with the patients, in English. So it's sometimes difficult when you train in abroad in a country where the English is not the first language. So you'll expect to provide some kind of English exam, which is IELTS, with a minimum score of 7.5 in each domain. The other one is the OET exam with a minimum score of 400 in each domain. Or you can ask one of your consultants, if you're currently working in NHS for more than 3 months, to write you a letter that you are able to speak English well, so that you can use as a proof of language and communication skill. And the other essential criteria is assess in the interview that you are able to understand the importance of patient as a central focus of care, and ability to prioritize tasks and information appropriately, and initiative and ability to deal effectively with pressure and or challenge and understanding of principles of equality and diversity. So NHS is a very complex structured hospital healthcare service, so you need to deal with lots of issues and able to prioritize your care for the patients. So that is important. And the other essential criteria is fitness of practice. So you will get criminal record check like DBS. That's it. So you need to have a DBS before you start your foundation year 2. I got some questions I can go through before I go to my experience.
Yes, shall I read you the questions then?
Yeah.
I think we have one question about CV. I think this is for me. I'll reply that one later on, so I'll ask your questions. What can we do as evidence of maintaining clinical knowledge and skills if you are not been practicing continuously?
You can attend some courses, workshops to gain skills. You can go conferences that have really good CPD points, and basically that. Yeah, just attend more lectures and conferences in the area that you want to specialize in. Will be better for your future applications for other specialties.
Great, thank you. And next question from Fatma Giray: is it better to apply for an standalone position or to search for junior level trust jobs? In which option do we have a higher chance of securing a position?
So I'll come through to this at the end, but the specialty foundation year 2 standalone application is becoming more competitive. But at the same time, the non-training jobs are also becoming more desirable now. I'll come through to that at the end.
Okay, and other question, isn't ALS equivalent to ILS, or would I have to do an ILS course as well?
No, if you've done ALS, it is the top of the life support. So it's advanced life support. ILS is immediate life support. So if you've done ALS, you don't need to do ILS again, or BLS as well.
Thank you. And other question is, do we have any say in the rotations we are assigned in FY2, or are they mostly predetermined in areas of requirement?
You generally don't have a say. You can, very rarely, you can ask other F2 to swap your rotation with them, but it's generally not done because you need to tell the TPD within a year advance. So it's so difficult to find that person and swap your training rotation.
Okay, thank you. And last question, I think this might be available on handbook, so I don't know if you want to reply that. Would an overall IELTS score of 8.5, but with a writing score of 7 not be accepted?
No, it wouldn't. You need 7.5 in each domain.
Okay, and we have couple of questions about rotations. Shall we leave them after your experience bit?
Yeah.
Okay.
So Alison, if you can move towards the end of the slides. I'll say stop. Yes, so I'll talk about my experience as a standalone FY2. I'll give you a bit of a background of myself. So I graduated in 2019 and I started working in London as a clinical fellow and a junior clinical fellow in rehab medicine. Then I decided to apply to training. So I applied for standalone FY2 because I didn't have enough working experience to apply for specialty training. So I applied in 2019 and the COVID hit. So everything kind of messed up for a bit. And then they did restarted the interview process and in March. So I had my interview in March, April, around that time, 2020. And I started my FY2 standalone in August and finished it next year. So I'll talk about three pros and cons of working as a standalone FY2. So if you go to the first one, yeah. So the first one is dedicated supervisors. So you will, as a standalone FY2 trainee, you will have a clinical supervisor assessing your day-to-day practice. They are the doctors who are looking after how you manage patients in your ward, how you deal with complex issues. And they are the doctors who are setting goals at the beginning of your rotation and helping you to achieve them. So throughout the year, you will have one education supervisor who are going to overview your training, and you will have three different, according to your rotation, three different clinical supervisors, different supervisor on each rotation, and your clinical supervisor will be a consultant that you are doing your rotation in. And the education supervisors, as I said, they supervise your overall training and they make sure that you're progressing through your year at an expected level and ready for your ARCP, which is the appraisal for every trainee to have at the end of their training year. And they should support you finding the right network to do projects such as audits, research, but also guide you on your training application. So your education supervisors tend to be the first clinical supervisor. So your first rotation supervisor will also be your education supervisors. But in my case, I had an education supervisor who was a trauma orthopedic consultant, and I didn't do any TNO job. But he helped me to find correct people to help me to do some projects that helped me for my IMT application. And also helped me to kind of go through my application for the IMT, and also help me with my exams, when to have my exams and how to plan studying for them. Yes, if you go to the second one. So as a foundation year 2, you're part of a great team. So not only the FY2s, but FY1s will be around you all the time. So in my FY2 year, there were around 30 of us in the foundation training, and you basically work together in the same ward. You do night shift together, You deal with issues together. You watch the foundation training teachings in the maths together, and you apply the specialty training together. So you kind of build this relationship with them, and this peer support is really important to kind of survive the foundation year. And you build up a really good relationship with them, sometimes like lifelong. One of the things to mention is that when I graduated, I wasn't sure how good a foundation doctor should be. So I was quite skeptical about like, what should I know? What should I not know? Like, how much should I know when I'm coming to work in the UK as a first time IMG? And working with other foundation doctors, you see your gaps in skills where you need to improve yourselves. And also it kind of reassure you that, oh, there's some foundation doctors who are not as good as the other ones. And that's the third, no. Yeah, so the third one is the rotations that you will never get as a non-training SHO. I never seen a clinical fellowship job in a GP practice, and a lot of doctors apply for GP training. I was able to do a GP training when I was an FY2, and I worked with a really good GPs and other healthcare professionals, and I realized that I didn't want to do a GP, although it was a good rotation. And I have few of my friends who applied for GP training and not having done any GP kind of rotation or any shadowing since their med school years. So when they started their GP training, they realized they didn't actually like that, so they gave up their training numbers. And there are other specialties which you don't get much of clinical fellowship posts, which are psychiatry. So most of the time, psychiatry jobs are for registrar level. The other specialties are like palliative care, microbiology, histopathology, nuclear medicine, and dermatology. So these are more specialized specialties that you don't get to do much as an SHO level. So these are really good if you are keen to go ahead for GP training to get an experience before you apply for your training. Yes, and the cons. So the first one is you're going to be called a baby doctor, which kind of shook me a bit when I first started, because they know that you are recently graduated, although some people who apply for foundation year training from a different country could have lots of experience. And I was working as a non-training SHO beforehand, and getting into Standalone FY2, I kind of downgraded as people started to trust me less because I was an FY2. Especially in August when you just become an FY2, because lots of them were an FY1 before. So you need to make sure that they trust you, but they realize that you kind of, if you are keen to learn and if you're reliable, they tend to trust you more within a couple of months. So that's not an issue to worry. It is something that you can change by just showing that your enthusiasm about working. The opposite to do with the specialties that you don't get exposure too much is the specialties that you don't want to do as a future career. For me, it was ED. I did GP, clinical oncology, and ED in Colchester Hospital. And ED gave me lots of stress about 4 hours target and seeing surgical specialties, like surgical presentations. And I think I didn't have a great foundation colleagues and seniors and consultants. I wouldn't survive the ED, but it's just me. So if you are keen to do ED, it's good that you kind of do a GP, a foundation FY2. And I think, having said that, working ED gives you a lot of great skills that you can use in your future career. I know that it definitely helped me during my IMT years. And because you get to see lots of surgical presentations, gynecological presentations in your patients who are in the medical ward. So it's good to have an idea about anything, basically. The other thing that I can mention is that I worked with foundation doctors when I was when I was an IMT, who did medical medicine rotation first and then become a surgeon, and then they were really good at finding medical issues earlier and kind of missed during their ward rounds with the surgeons. So I think it's really good that you get different exposure, so you tend to build more skills and knowledge around medicine. Yeah. And the last one is the desired location. With the rising competition ratios in every specialty and non-training fellowship jobs, it is no surprise that FY2 standalone competition has rising. In 2022 April, the UK FBO published that the competition ratio is 3-1. So there's one post and 3 people applying for it, and it's becoming more and more competitive. So you might end up in an unfavored DGH or less favored DGH in a place where you never heard of. I think don't just panic. Sometimes these hospitals are offer the best training for their juniors, and it's just only 1 year, so you can make lots of nice friends from your foundation doctors, and you can do fun things with them outside of medicine. And some people choose to live there after their training. So that if I went to Colchester, and Colchester would be somewhere I would never actually go, but it was really good to spend a year outside of London to come back to London. So it's really good that you can kind of get something from it, even though you move really away from where you were originally. Yeah, that's it. Thanks. Any questions? Yes. Do you want to start with the questions, Alisa?
Oh yeah, sorry. Yeah, my microphone was sorry. Yeah, I'm just trying to go through the questions. What was the last one you done, Rabia? Sorry. The last question you asked, Umar. Do you remember? You're muted. Sorry.
Sorry. So where they ask how hard are the requirements in the rotations and getting signed offs for the portfolio.
Okay.
So unfortunately, the requirements are not really hard, and it's just like someone needs to tick those boxes. You need to do mini cases, so clinical evaluation supervised by a senior doctor. You need to get CBD, case-based discussions. So I'm not sure what is the current guidance, because it changes every year with every ARCP. You need to get multi-source feedback. So if you complete all of this, which is easy to complete, and if you attend most of your foundation year training, teaching sessions, it's easy to go through your next rotation. It's not a big deal.
Thanks. The next question is, for someone who's dreaming to train in orthopedics, do you consider FY2 standalone a good place to start from?
I actually do, because when I was choosing where I want to go, I want to do oncology. I knew it, so I chose places which had oncology and avoided all the surgical specialties. And there were lots of TNO job, and I think if you are doing FY2 TNO, you gain a lot of skills, and also it's really good for your future interviews when you apply for TNO. So I would definitely recommend you.
Thank you. And the next question is, how can we as junior doctors get experience in general practice field? Experience prior to applying to GPST1 training before seeing the MSRA exam. I think, yeah, Umar actually answered this already. If you apply for standalone FY2, that is the way to get a GP trainee, GP practice experience. Otherwise, it's not possible to get a non-training job in GP. So yeah.
We can shadow. We can do like a
Oh yeah,
test
yeah,
a bit.
absolutely, yeah.
Well, even though you're not allocated a job with a GP, you can ask for 2 weeks, or I think it's 1 week in each year of going to do something else that you enjoy.
Yeah, absolutely. Yeah, that's a good point. Yeah, you can always do like shadowing and observerships. The other question is, could you please share your background more with us, like language and working experience before the FY2 standalone? I think Umar answered this, but I don't know if you like to share a bit more.
Yeah, so I did graduate in 2019 after done an internship here. So I had the full registration when I first came. And I did a year at like 10 months in rehab medicine as an SHO. And I had done IELTS in the past. So.
Thank you. In the hopes of getting shortlisted and passing the interview, how do we go about preferencing? You also mentioned a bit about this, isn't it? Like, you just need to probably look at the specialties you want to do, specialties you want to avoid. Also, location-wise, I don't know how picky you can be. Obviously, probably depends on your rank. But
there was a really good website, but I forgot the name. I couldn't share it. It was about foundation doctors ranking their hospitals. I don't know if
I can share that. Yeah.
So you can see which hospitals are favored by their foundation doctors and which specialties are better than the others in that hospital specifically. So you can have a look. I think I would definitely suggest you to go to the specialty that you want to do in the future, or if you're in between two different specialties, you can sometimes find them together.
Thanks. If you don't have a continued employment history, as we took the PLAP exam during those gaps, will it be an issue? I don't think it's an issue for standalone FY2, as long as you have the GM's registration. Is it recommended to read just the emergency section of the Oxford Handbook of Foundation Doctors? Would that be sufficient for the interview?
I leave it to Rabia.
Well, no one can guarantee which medical topic the question would be on. So I don't only suggest foundation book, emergency section of the foundation book. I would say definitely know all the emergencies like back of your hand, but have some ideas about other stuff as well. You can be a ward in neurological ward or surgical ward or whatever, all the specialties that Omar mentioned. So you can get questions from other specialties as well. So you need to have some sort of knowledge if you want to score high.
Thanks. Another question I can answer this directly. It says, can we ask CREST form to be signed during the FY2 program? You don't need CREST form if you do FY2. You can just directly apply.
Yeah, so when you're doing application, you can just tick the box that you're a current FY2 trainee. So you get completion of foundation training program at the end of your foundation year 2. So you can just automatically get pressed, basically.
Yeah, absolutely. Yeah, CREST form isn't just an alternative to show that you have the competencies of an F2. The other question, what is the best job to apply for someone who has worked for over 5 years as a medical officer in a multi-specialist private hospital interested in emergency medicine? I mean, you can both apply for standalone FY2 or you can apply for non-training jobs. I mean, if you have a registrar level, specialty level experience in emergency medicine, you can even apply for senior level jobs. But yeah, I mean, standalone FY2 is also an option always. However, is it on the practical skills other than phlebotomy? Is it easy to request supervision? Have you got any issues with that, Umar? But you were probably, I mean, you were working before them.
your FY2 skills that you need to be competent are very basic skills like ECG interpretation, like phlebotomy, gas, urinary catheterization. So it's quite peak flow reading, so it's quite easy. They don't need much supervision for that. But if you're going to do chest strain, you probably need a supervision, and it's not one of the mandatory skills that you need to achieve by the end of foundation year.
Wonderful, thanks. Also, how is the salary like for F2 standalone? It is the similar. It is. I'll just put the link actually. Yeah, it's from the BMA. I mean, salaries are not great. That's
And
why
it
we
will
are
change a
striking.
lot as well,
Yeah.
because if you do GP, you don't do on calls, you get less money. If you do medicine or ED, you get lots of on calls, you get better money.
Yeah, salaries will be definitely like all other topic. It just there are lots of different factors for your take-home monthly pay. There is not really a set amount. It can be somewhere around 2,000 to somewhere around 3,000, all depending on how much on-call rota, how much weekends or how much night shifts you are doing. Okay, what's the implication of not having license to practice, but having full registration with respect to job application? Yeah, as far as I know, there is not an issue with that as long as you got your registration. The other question is, maybe you can answer this, or the FY2 program starts in August. Can we apply for round 1 in November, same
Yes.
year? Yeah.
I did that.
So yeah, that's how it works, isn't it? Like specialty applications. So if you, let's say, for the 2025 August 2025 start, you need to apply in November 2024. Can people
apply all together, so you can just check what other people are doing for their application?
Thank you. Can people doing F2 standalone get locums to do as well?
Yes.
Yeah, you can definitely. And the last question, SJT result for this year will be released on April 10th. Will you hold another mock interview session prior? We are not really considering to do another mock session, but if you can just register with our website to just keep an eye on other sessions. We might not be just do like specific FY2 mock interview session, but we can do a different one. And also, I just want to put our courses. Thank you to our amazing speakers for the time. I think it was really amazing. I learned a lot as well. So thank you. Yeah, and yeah, we will make the recording available for those joining late or for those who just want to listen again. Yeah, take care, and yeah, let's be in touch for the future webinars. Thank you.